Dear colleagues and PGs, Assalamu alaikum. We are discussing the steatotic liver disease or fatty liver disease. Till now, we have learned the new terminology introduced by the NAFLD last month. That is on 24th June 2023. Then we discussed what is the fatty liver disease, what is its definition, what is the pathology, and what's the clinico-pathological correlation. Today we shall discuss the pathophysiology of steatotic liver disease or fatty liver disease. As I said, today we are discussing the pathophysiology of steatotic liver disease. The pathophysiology is really a complex and needs to know the basics in somewhat details. Before proceeding to the specific pathophysiology or depths of the pathophysiology of the steatotic liver disease, let's briefly summarize or recall the physiological roles of insulin. We know that the major purpose of insulin is to regulate the body's energy supply by balancing micronutrient levels during the fed state. So when a patient eats and takes the energy in form of the sugar and the carbohydrates and others, so the major purpose of insulin is to regulate the body's energy supply by balancing macronutrient levels. So it balances the fats, the proteins, the lipids, and the sugar. Insulin is critical for transporting intracellular glucose to insulin-dependent cells and tissues. We know that it's critical for transporting intracellular glucose to insulin-dependent cells and tissues such as liver, muscle, and adipose tissue. Any imbalance in exogenous energy supplies, if the patient takes a lot of lipids, a lot of carbs, the glucose, it results in the breakdown of fats stored in adipose tissues and eventually accelerates insulin secretion. So if there is an imbalance and if it's a high amount of one or less amount of one, there is imbalance, the balance is depressed. We know that when the insulin is secreted by the beta cells, this is the islets of Langerhans, the beta cells of the pancreas, and it comes into the blood, it has got different actions in the liver, in the skeletal muscle, and in the adipose tissue. In the liver, what it does, it stimulates and it incorporates the glucose into glycogen as well as into fatty acids. So in the liver, the glucose is taken from the blood and this is stored in the liver in the form of the glycogen as well as in the form of into the fatty acids. And on the other hand, the gluconeogenesis process, it is inhibited by the insulin. So what does it mean? That glycogen, the glucose is utilized or taken from the bloodstream and converted into glycogen, so the blood sugar level is regulated, as well as it blocks the process of glycogenolysis. So the glycogen is stable. It does not break down to release the sugar, so the RBS levels is controlled. Similarly, it converts the glucose into fatty acids, then triglycerides, but the gluconeogenesis, which is normally when the patient is in fasting state and the gluconeogenesis is formed, it inhibits that process. So what it does in the liver, that it lowers down the sugar level, it converts that into glycogen as well as into the fatty acids, and the reverse processes which leads into increase in the blood sugar levels like glycogenolysis and gluconeogenesis, they are inhibited. What's its actions in the skeletal muscles? When through insulin, under the effect of the insulin, the skeletal muscle takes the blood, glucose from the blood, and then there is glycolysis and the ATP is formed. And there is the protein synthesis of the amino acids. And it inhibits the process of proteolysis. So again, the insulin is important for utilization of the amino acids and glucose in the skeletal muscles. Similarly, in the adipose tissue, when the sugar is taken, nutrients are taken under the effect of the insulin, there is lipogenesis, and the fatty acids, they are changed into triglycerides and stored in the fat cells. And the reverse, which the lipolysis or the triglycerides are changed or broken down into fatty acids, that process is blocked. So insulin makes sure that the nutrients, micronutrients, the glucose, the fatty acids, and the amino acids, they are utilized in the peripheral tissues. The fatty acids in the adipose tissue, the amino acids in the adipose tissue, and fatty acids and glucose in the liver, as well as utilized in the muscles, as well as in the adipose tissue. We must know something about the classical insulin signaling pathway. I won't go into the detail of that, but there is insulin receptor, there is transporter, the glucose transporter, and then there is intracellular different cell lines, and the GLUT4 translocation, then the vesicles, then different cytokines, and of course in the cytoplasm, nucleus, and all these energy processes we must know, and this is not the time to go into detail of that, but this is very important because in the case of type 2 diabetes or insulin resistance, insulin is there, rather it is present in the excessive amount, but this post receptor signaling pathway, they are faulty and they don't respond accordingly to the insulin, so the insulin lacks its intracellular effects in the case of insulin resistance. Now concentrate on the liver, the concepts of the metabolic compartments in the liver. This is the liver, this is the lobules pattern, the central vein, and the connective tissue, and the lobules, and this is the, I've shown the lobule, this is the hepatic vein, interlobular hepatic vein, this is the central vein, these are the portal vein, portal artericles, the bile duct, and these are the sinusoids. So hepatocytes can be classified into two main types, the periportal hepatocytes and perivenous hepatocytes. Those hepatocytes which are adjacent to or close to the portal area, these are called periportal hepatocytes, and those hepatocytes which are nearby the central vein, these are called perivenous hepatocytes. The metabolic activities in both of these is different from one another. Like here, the blood supply is oxygen rich in the periportal hepatocytes and less in the perivenous hepatocytes. Then the oxidative metabolism is predominantly happening in the periportal hepatocytes, while the gluconeogenesis and glycogenesis also happening in the periportal hepatocytes. On the other hand, the fatty acid synthesis, fat lipid metabolisms, these are predominantly happening in the perivenous hepatocytes. So if I concentrate or take this is the portal vein, this is the central vein, these are the periportal hepatocytes, these are the perivenous hepatocytes. So in the insulin resistance, when the inside are the cells, the intracellular, the secondary messengers pathways. They don't respond the way they should to the insulin stimuli. When they don't, so what happens? This state are in the state of insulin resistance. There's difference in periportal and perivenous hepatocytes. In the periportal, which is the glucose production, and here in perivenous, which is the lipid synthesis, there is imbalance between these two. Subsequently, there's excessive production of glucose here, and there is accumulation of lipids seen in the liver of proteins, obesity and insulin resistance. So both these cells, they behave differently. So if I summarize the pathophysiology, the patient has got most of the times the genetic predisposition, especially in the forms of the PNPLA3 predisposition, and then the diet high in the carbohydrates and high in the fat. It will lead to dyslipidemias or fatty toxicity or lipid toxicity and glucotoxicity. And then these will stimulate or activate the macrophages, then the pro-inflammatory cytokines and different other cytokines, JNK, IKKB, and then it will set up the inflammation, and the hyperglycemia will lead to increased concentration of redox oxygen species, and this diacylglycerol, the dyslipidemia will lead to that. And both of these, they lead to insulin resistance. And in the insulin resistance, on one hand, there is a high production of the glucose, because now the periportal hepatocytes, where the normal mechanism was that the glucose used to be utilized in terms of the glycogen and the glycogenolysis processes, gluconeogenesis process used to be inhibited. Now that is not inhibited, and there is less consumption of the glucose in the form of the glycogen, and there's increased production of the glucose over there. While in the case of the perivenous, again, there is the increased fat deposition, because now here the fat which used to, the insulin which used to inhibit the fatty, which I told you, the fatty acids production from the triglycerides, it is not done there. So this is the whole mechanism is disrupted, and the liver becomes fatty, and the insulin resistance metabolic syndrome ensures. So when the patient is obese, it leads to pre-diabetes state and then into a type 2 diabetic state. So with this, I stop here. The main thing is that because of the diet high in carbs, high in lipids, in genetic disposition, when this goes, there is the lipotoxicity, there is the glucotoxicity. Both these leads to different intercellular mechanisms. There is a source of inflammation, and because of the inflammation, there is damage to the intracellular cytokines and messenger pathways, and now there's insulin resistance. It starts in the liver, and normally which it used to use the glucose, convert that into glycogen, and it was inhibiting the glycogen into glucose, and also it was inhibiting the gluconeogenesis. So when those processes are inhibited and there is less or no conversion into glycogen, so high blood sugar levels there, and there is a high sugar level, and then this is the triglycerides level deposition is there, and then triglycerides goes to the other side, the adipose tissues, there it gets deposited. So the whole thing starts. And in the obesity or in case of insulin resistance, first of all, the liver becomes fatty, and after that, these are the peripheral deposition of the fat. So now the concept is changed. We used to say that when the patient is obese, the liver becomes fatty. No, this is the other way around, that the liver starting becoming fatty, In insulin resistance, first this liver, the fats stops depositing in the liver, and then when that is full, then liver starts depositing in the other tissues of the body. So I stop here. We shall meet in the next video, inshallah, regarding the best current practices of the fatty liver disease treatment. Till then, Khuda Hafiz.